This conference will now be recorded.
Today's topic is role of eye camps in prevention of blindness and eye banking. Eye camp approach for prevention of blindness still plays a vital role in the developing countries where infrastructure is not fully established. It is particularly more relevant in keeping in view the fact that still 62% of the blindness in India is due to cataract, which can be very well cured in eye camps. Mainly 60% of the cases of blindness is due to cataract only, and it is completely preventable. So eye camps are very important in India. Presently, there are two types of eye camps: comprehensive eye care camps with reach out approach, where we will go out to the patient and set up a camp and do the screen the cases, and we do surgeries. And screening eye camps, reach in approach, where the patient will come to the community health center or PHC and surgeries will be done in that center. That is reach in approach. One is reach out approach, where we go out and we set up a camp and do the surgeries there itself. That is reach out approach. Reach in approach is the patient will reach the nearest PHC or community health center, and the surgeries will be done in that center by an trained ophthalmologist. That is reach in approach. There are two types of approach. One is reach out approach and other one is reach in approach. These are the pictures showing eye camps. This one is mass screening of the children for refractive errors. School children for refractive errors. This is prescribing the glasses following cataract surgery. Comprehensive eye care camps with reach out approach consists of preparatory phase, where we go out and reach out to the panchayat office or president of the local village, and we inform them that we are conducting a camp. That is the preparatory phase. And second one is the intensive phase, which is for 2 to 3 days. And the third one is a consolidation phase. And fourth one is a culmination and retrieval phase. And fifth one is follow-up phase. These are the five stages of comprehensive eye care camps with reach out approach. First one is preparatory phase. Second one is intensive phase for 2 to 3 days. And third one is consolidation phase for 4 to 5 days. And fourth one is culmination and retrieval phase. And last one is follow-up phase. They are the 5 phases of reach out approach. Preparation phase includes finalization of the organizer and medical team, where we finalize the medical team, and it includes coordination by the district blindness control authorities. Medical team includes district mobile ophthalmic unit or charitable hospitals or state mobile ophthalmic units. This is the medical team, which includes a charitable hospital or a district mobile ophthalmic units or a state mobile ophthalmic units. And second stage for preparation is permission to hold the eye camp. Permission to hold the eye camp should be given by the chief medical officer or civil surgeon of the district. And selection of the eye camp, it is held at the community health center or PHCs or charitable hospitals or civil hospitals, so that the available operation theatre facilities can be used. The place should be have a ophthalmic theatre, not other theatres. It will have a specifically ophthalmic theatre with microscope and other equipment to conduct the cataract surgeries. It is usually held at the community health centers or charitable hospitals or civil hospitals or PHCs, so that the available operation theatre facilities can be used. These are the preparation. 3 persons which are involved in preparatory phase. Finalization of the organizer and medical team. Permission to hold the camp should be given by the chief medical officer or the civil surgeon of the district. And selection of the eye camp, where the eye camp should be set up. It should be held at a community health center or a PHC center or a charitable hospital or a civil hospital, so that the available operation theatre facilities can be used. You should have a particularly ophthalmic theatre, not other theatres. Ophthalmic theatre is different from the other theatres. You cannot perform the surgeries in other theatres. You should contain microscope and other ophthalmic instruments so that the surgeries can be done. That is the preparatory phase. Publicity and mobilization of community resources. Publicity should be started at least fortnight prior to the actual camp dates. Method of publicity includes public announcements, radio broadcast, display of banners and posters at the prominent places like bus stands, railway stations, and schools. This is the publicity. Other activities includes medicine, food for the patients, stay arrangements for the medical team, mobilization of volunteers and social workers. These are the other activities. Medicine for the and food for the patient, medicines and food for the patients, stay arrangements for the medical team, and mobilization of volunteers and social workers. These are the other activities. Intensive phase includes the medical team, the resident doctor. Medical team includes the resident doctor, nurses, operation theatre assistants, and paramedical personnel. Reach the campsite an evening before the scheduled commencement of the camp. The medical team should reach at least before the day of starting the surgeries or starting the camp, at least on the evening of the day before starting the camp. Set up the OPD, ward, and operation theatre. So that the medical team will set up the OPD, ward, and operation theatre. The OT room should be fumigated with formalin vapors and kept closed overnight. The OT should be sterilized, completely sterilized, and should be closed overnight. The intensive phase includes the medical team, the resident doctor, nurses, operator theatre assistants, and paramedical personnel. They should reach the camp on the evening before the scheduled commencement of the camp. Set up the OPD, ward, and operation theatre. The OT room should be fumigated with formalin. This is the intensive phase, where we are preparing for the camp and surgeries. That is called intensive phase. Patients are provided comprehensive eye care services, including refraction, surgical intervention for cataract and other diseases. For performing ophthalmic surgery, following guidelines are laid down by Government of India. At least one anesthetist should be there. At least one, preferably two operating surgeons should be there. Ophthalmic surgeons should be there, and each surgeon should not perform more than 30 operations per day. For sterilization purpose, for maintaining the quality of the surgeries, the number of surgeries, cataract surgeries should be performed should be at only 30 surgeries per surgeon. Presently, ECCE means extracapsular cataract extraction by any technique, preferably manual SICS or pack emulsification with PCI oil. Postage chamber IOL implantation is the recommended method. There are the following guidelines issued by the Government of India. At least one anesthetist to meet common emergencies. If there are emergencies, most people are old age, they will have cardiac problems, diabetes, hypertension, asthma, all these comorbidities will be there. So at least one anesthetist should be there to attend the medical emergencies. Preferably two operating surgeons should be there, and each surgeon should not perform more than 30 operations in a day. And the best surgery is ECCE by any technique, preferably manual SICS or pack emulsification with PCI oil implantation is the recommended method. Ideally, number of operations performed should not exceed 50 per day. If both the surgeons are operating, it should not exceed more than 50 per day and should not exceed 200 per camp to maintain the quality and safety of sterilization, surgery, and post-operative care. Both the eyes should never be operated at one go, because if one eye gets infected, other eye also gets infected. So never, both the eyes should not be done. Surgery should not be done at a time. Cases with poor surgical risk, severe diabetics, severe hypertensives, and those having cardiac problems are not operated in the camps and are referred to the base hospitals. They are referred to the base hospitals. Eye health education is carried out simultaneously along with curative and preventive services. This is the intensive phase. Consultation phase, care of operated and other admitted patients, outpatient care including refraction, community outpatient should be given, refractory correction should be given, and glasses should be given in consultation phase. and post-operative care of the admitted patient should be taken. Community eye health and morbidity surveys with greater emphasis on school children. School children should be screened for any refractive errors and they should be screened for any squint, cataract, nystagmus, any congenital glaucomas. All these conditions should be screened for children. Culmination and retrieval phase. On the morning of the last day, each patient is carefully examined and discharged after proper guidance. After this, the men and the material resources packed up and transported back to the base hospital. This is the culmination phase. Follow-up phase. Follow-up examination after 46 weeks of closing the camp. 4 to 6 weeks. It is not 46 weeks. It is 4 to 6 weeks after closing the camp. Done by the ophthalmic surgeon with the help of one ophthalmic assistant, one staff nurse, and paramedical person. During this phase, glasses are prescribed after removing the sutures and patients are given further advice, necessary advice. This is the follow-up phase. Follow-up phase should be done after 4 to 6 weeks, not 46 weeks. This is wrong. 4 to 6 weeks closing the camp. Done by the ophthalmic surgeon with the help of ophthalmic assistant, one staff nurse, and another paramedical person. Then follow-up phase, the patient should be given glasses and any sutures applied should be removed. Screening of eye camps, reach in approach, and in rural and remote areas where the eye care facilities are not available, comprehensive eye care services including refraction are provided. Cataract surgery patients are transported to the nearest well-equipped hospitals, base hospitals. Base hospital approach is reach in approach, where the patients are transported to the nearest base hospital. That is called reach in approach. Emphasis is on ECCE and with PCIOL implantation for better quality of vision. Recently, sutureless SSCS or with PCIOL implantation or phacoemulsification is the emphasis. This is the reach-in approach, where the patients are transported to the nearest base camp and surgeries are performed at the nearest base hospital. And emphasis is on ECC, extracapsular cataract extraction with PCIOL, particularly with sutureless small incision cataract surgery and PCIOL implantation. That is eye camps, eye banking. It is a non-profit community organization which deals with the collection, storage, and distribution of cornea for the purpose of corneal grafting, research, and supply of the eye tissue for other ophthalmic purposes. It is a community organization, non-profitable community organization which deals with the collection, storage, and distribution of the cornea. Collection, storage, for the purpose of corneal grafting, research, and supply of the eye tissue for other ophthalmic purposes. In 1906, Edmund Jerome, first successful corneal transplantation was performed by Edmund Jerome. In 1937, V.P. Filatov, father of the modern eye banking. 1949, first eye bank in India was established by Dr. Muttaya in Chennai. In 1961, Eye Bank Association of America was formed. In 1974, McCarry-Kaufman medium was invented. MK medium is preservation of the donor corneas. You have to preserve the donor corneas. In MK medium, you can preserve the donor corneas for 24 to 48 hours. This is the most commonly used medium. MK medium is the most commonly used medium for preservation of the donor cornea. This is the steps in advances in eye bank. 1906, Edmund Jerome first successful corneal transplantation was done. 37, Filatov, the father of modern eye banking. 1949, first eye bank in India was established by Muttaya in Chennai. 1961, Eye Bank of Association of America is formed. 1974, MK medium was discovered. MK medium is McCarry-Kaufman medium. This is the medium most commonly used for preservation and transport of the donor corneas. After retrieving the cornea or eyeballs, they should be preserved for at least 24 to 48 hours. Otherwise, the endothelial cells gets damaged and it cannot be used for the transplantation. So the medium most commonly used is MK medium. MK medium, the donor cornea can be preserved up to 24 to 48 hours. Eye bank consists of board of directors, medical director, eye bank director, recovery technicians, donation coordinators, processing technicians, research facilities, specialists will be there, distribution of the specialists. This is the eye bank. Functions of the eye bank: promotion of eye donation, registration, collection, receiving and processing, preservation of the, after receiving and processing, should preserve the donor corneas, and distribution of the corneas for the necessary person, and research activities. These are the functions of the eye bank: promotion of eye donation, registration of eye donation. Patients who are willing to, people who are willing to donate the cornea, they should be registered, and collection should be done, and receiving and processing of the donor cornea should be done. After receiving and processing, they should be preserved. After preservation, they should be distributed for the people who are required, and it can also be used for research activities. These are the functions of eye bank: promotion of eye donation, registration, collection of the donor corneas, receiving and processing of the donor corneas, preservation of the donor corneas in MK medium, and distribution to the required people who are required. The patients who require corneal transplantation, or the hospitals which require corneal transplantation, which are the facilities for corneal transplantation, they should be distributed, and research activities. These are the functions of eye bank. This is the pyramid: 2000 eye donation centers, and it should contain 45 eye banks and 5 eye bank training centers. This is the pyramid of eye bank organization: 2000 eye donation centers and 45 eye banks and 5 eye bank training centers. This is the pyramid for eye bank donation. Eye bank personnel: eye bank in charge, eye bank technician, clerk cum storekeeper, PRO, driver cum projectionist. This is the eyes. Entire eyeball is retrieved and stored in the medium. This red one is the MK medium, mechanical medium, where the sclerocorneal button is stored in the medium. Here the entire eyeball is stored in the medium. Here the sclerocorneal button is stored in the medium. This is the medium, MK medium. This red color or orange color is the MK medium. Legal aspect: the Transplantation of Human Organs Act 1994. Written informed consent should be taken from patients who are willing to, persons who are willing to donate the cornea, and relative decision. Informed consent should be taken, and relatives. Facts about eye donation: it should be collected within 6 hours of death. Care of eye should be taken after death. It takes 15 to 20 minutes to collect. Eye donation person gives sight to 2 blind persons. Each cornea can be utilized in 5 cases. They are never bought and sold. The corneas are never sold. They are never refused. If a person wants to donate the cornea, they are never refused unless they have certain issues like HIV, HBsAg, HCV, Creutzfeldt-Jakob disease, certain glaucoma, or certain conditions are there, contraindications for unless certain contraindications are there, they are never refused. Can be removed from living person, cannot be removed from living person. Even if the person gives consent, you should not, you cannot remove a cornea from the living person. If they give consent also, you should not remove a cornea from the living person. These are the facts about eye donation. They should be collected within 6 hours of death. Care of eyes to be taken after death, and it takes 15 to 20 minutes to collect. And the eye corneas are never sold. They are never refused. If a person wants to donate a cornea after death, it is never refused. And it should not be taken from a living person. The cornea should not be taken from a, even the person gives a consent, it should not be taken from a living person. Eye donation: any person can donate an eye at any age, any religion can pledge to donate the eyes. Relatives also can pledge to. Contraindications: there are certain systemic and ocular contraindications for retrieving the donor cornea. A person, death due to unknown cause, death due to AIDS, rabies, hepatitis B, hepatitis C, Creutzfeldt-Jakob disease, subacute sclerosing panencephalitis, Reye's syndrome, leukemias, lymphomas, lymphosarcomas. There are all the systemic contraindications for collection of donor corneas: AIDS, rabies, hepatitis B, hepatitis C, active viral hepatitis, Creutzfeldt-Jakob disease, subacute sclerosing pancreatitis, Reye's syndrome, leukemias, lymphomas, and lymphosarcoma. These are all the systemic contraindications for connection of the donor corneas. Ocular contraindications include ocular diseases like retinoblastoma, active conjunctivitis. If a person has iritis, uveitis, vitritis, or retinitis, keratoconus, central corneal opacities, pterygium, prior refractive procedures, right, radial keratotomy, scars or lamellar inserts. If the already a LASIK or any refractive surgeries are performed, like radial keratotomy, scars are there, or lamellar inserts are there, these are all the contraindications, ocular contraindications: retinoblastoma, conjunctivitis, uveitis, keratoconus, central corneal opacities, pterygium, prior refractive procedures like radial keratotomy, scars, and lamellar inserts. These are the ocular contraindications. These are the systemic contraindications for taking the donor corneas, for retrieving the donor cornea. These contraindications are very important. They can be asked in entrance also. Which are the following are the contraindications for taking a donor cornea? AIDS, rabies, active viral hepatitis, Creutzfeldt-Jakob disease, SSPE, subacute sclerosing pancreatitis, Reye's syndrome, leukemia, lymphoma, lymphosarcoma. They are the systemic contraindications. Ocular contraindications includes retinoblastoma, conjunctivitis, uveitis, vitritis, retinitis, keratoconus, central opacities, pterygium, refractive procedures like radial keratotomy, scars, and lamellar inserts. These are the contraindications for procuring the donor cornea. You can take an entire eyeball. Enucleation means you can take an entire eyeball, or you can take a corneoscleral button. Anyone can be taken. And you should take the blood sample for HIV, hepatitis B, hepatitis C, syphilis, lymphomas, and corneal evaluation should be done. Excellent, very good, good, fair, and poor, based on the endothelial cell count and cell shape. Storage should be done in short-term storage, intermediate storage, long-term storage, and very long-term storage. Long-term is tissue culture, very long-term is cryopreservation. These are the storage medium. Short-term storage, 2 to 3 days, moist chamber method. I already told you. MK medium means McCarry-Kaufman medium. 7 to 10 days. Kazol, Dexol, or Aptisol. Dexol contains dextran. These are the various medium for preservation up to 7 to 10 days. Intermediate storage. Long-term storage is up to 13 days. It is used in organ culture medium. And very long-term storage is 1 year. You can store the donor cornea up to 1 year. That by cryopreservation. The most important problem with cryopreservation is intracellular ice crystal formation, because the freezing is at minus 80 degrees centigrade. There will be formation of intracellular ice crystal formation. That itself will damage the cornea. This is the main disadvantage with very long-term preservation, intracellular ice crystal formation. These are the short-term storage, intermediate storage, long-term storage, and very long-term storage. Short-term storage is for 3 days. MK medium is used. Intermediate storage is 7 to 10 days. Kazol, Dexol, Optisol. There is a various medium for intermediate storage. Up to 30 days, you can use organ culture medium. If you want to store up to 30 days for long-term storage. If you want to store for 1 year, very long-term storage, you can use cryopreservation. The most important problem with cryopreservation is intracellular ice crystal formation. This is the enucleated eye. Entire eye is enucleated. This is the examination under specular microscope. This is the instrument specular microscope for endothelial cell count. The ideal endothelial cell count is 2500 to 3000 cell count should be there. This is the MK medium where the donor corneoscleral button is stored. This is the corneoscleral button. Instead of entire eyeball, the corneoscleral button is taken. This is the corneoscleral button. You should not evaluate for any change in the shape like polymegatism or pleomorphism, change in the shape, enlargement, increase in the size of the cells, is called polymorphism and pleomorphism. Pleomorphism is alternation in the size of the shape. That's what pleomorphism. S is for polymorphism and pleomorphism. Grading of the donor corneas. Number 1, excellent. No epithelial defects, crystal clear cornea, no arcus analis, no folds in the Descemet's membrane, endothelium, no defects. That is one, excellent. Grade 1, excellent. Rating is excellent. Grade 2, very good. Slight epithelial defects, clear stroma, slight arcus, few folds in the Descemet's membrane can be seen. Endothelium, no defects. That is good. Grade 2, very good. Grade 3 is good. Moderate epithelial defects, moderate cloudiness, arcus analis of 2.5 mm, numerous but shallow folds, few vacuolated cells in the endothelium. That is good. Fair means epithelial defects more than 60%, moderate to heavy stromal cloudiness, numerous deep Descemet's folds, arcus analis of more than 2.5 mm, low endothelial cell density. Poor means central epithelial defects, heavy stromal cloudiness, marked fold, marked endothelial cellular defects. This is the grading of the donor cornea. Excellent means no epithelial defects, crystal clear stroma, no arcus analis, no folds in the Descemet's membrane, endothelium has no defect. That is excellent. Grading is excellent, or grade 1 are excellent. Cornea is used for corneal grafting in blindness, corneal blindness. Sclera is used for glaucoma, oculoplasty, and retinal surgeries. National Eye Donation Month, March. Eye Donation fortnight, 25th August to 8th September. World Sight Day, 13th October, second Thursday. They are the important dates. World Sight Day is 13th October. One of the basic human rights is right to see. This grading is important. Grading of the donor cornea. Excellent means no epithelial defects, crystal clear stroma, no arcus analis, no folds in the Descemet's membrane, no defects in the endothelium. That is excellent. Very good means slight epithelial hairs or defects, clear stroma, very slight arcus, few folds in the Descemet's membrane, endothelium has no defects. That is very good. Good means moderate epithelial defects, moderate stromal cloudiness, arcus of less than 2.5 mm, numerous but shallow folds, few vacuolated cells in the endothelium. That is good graft. Poor graft means central epithelial defects, heavy stromal cloudiness, marked folds, marked endothelial cellular defects is poor graft. That is the graft quality. This is the grading of donor cornea. Eye banking is an important essay question for you, and eye camps is also an important question. Role of eye camps in prevention of blindness and eye bank. These two are, they can be asked as two separate 4 marks questions or two separate essay questions. Eye banking, you have storage medium, you can be asked as 2 marks questions or 1 4 marks question. Eye banking is an important essay question. Functions of the eye banking: promotion of eye donation, registration, collection, receiving and processing, preservation, distribution, and research activities. For about 2000 eye donation centers, there should be 45 eye banks and 5 eye bank training centers should be there. This is the eye bank organization. Eye bank personnel consists of eye bank in charge, eye bank technician, clerk cum storekeeper, PRO, driver cum projectionist. The Transplantation of Human Organs Act 1994, written informed consent should be taken and relative decision should also be taken. Facts about eye donation: it should be collected within 6 hours of death. Care of eyes should be taken after death. It takes about 15 to 20 minutes to collect the donor cornea. Eye donation person gives sight to two blind persons. The corneas are never brought and sold, they are never refused, but they cannot be removed from a living person in spite of their consent. Even if a living person gives a consent, it should not be taken. Any person, any age, any religion can pledge to donate the eyes. Relatives also can pledge to. There are the contraindications, systemic contraindications and ocular contraindications. Systemic contraindications include death due to unknown cause, AIDS, rabies, active viral hepatitis like hepatitis B, hepatitis C, Creutzfeldt-Jakob disease, SSP, subacute sclerosis pancreatitis, Rice syndrome, leukemia, PMLE, leukemias, lymphomas, and lymphomas. Ocular conditions like retinoblastomas, conjunctivitis, uveitis, vitritis, and retinitis, keratoconus, central corneal opacities, pterygium, rare refractive procedures like radial keratotomy, scars, and lamellar. These are all the contraindications, systemic and ocular contraindications. This is very important, systemic and ocular contraindications for taking a donor cornea. Storage medium, short-term storage, intermediate storage, long-term storage, and very long-term storage. Short-term storage for 2 to 3 days in MK medium, McCarry-Kaufman medium, or moist chamber method. Intermediate storage is 7 to 10 days in Kazal, Dexal, or Optisol medium. Long-term storage is 13 days, argon culture medium. Very long-term storage is up to 1 year for cryopreservation. There are the various storage medium, MK medium, Dexal, Optisol medium, argon culture medium, and cryopreservation. This is the grading of the donor cornea. Excellent means no epithelial defects, crystal clear stroma, no arcus senalis, no folds in the Descemet's membrane, no defects in the endothelium. No folds in the Descemet's membrane, no defects in the endothelium, no arcus senalis, crystal clear stroma, no epithelial defects. All the 5 layers. There is no defect in all the 5 layers. It is excellent. No epithelial defects, clear stroma, no arcus senalis, no folds in the Descemet's membrane, no defects in the endothelium. That is considered as excellent. Okay, thank you. ఏంటి సార్లు స్టెప్